having Jim Schmidt's team from the Boise area talking to us and sharing their experience and wisdom about what it is to be a hospice team. And we're recording this session for people who can't come. I have dropped in a list of reorganized list of all the questions that were posted so that we would be able to let Jim and his team know kind of what's on your mind to help guide the conversation. So I'm going to be using that more or less as a sort of an interview guide and an agenda for today's talk. And what I hope is, as you see this list, if there are questions that you are prompted to want to add to the list when we come to that part of the discussion, just pop them in the chat and we'll try to respond to as many as we can with the time that we have. Without further ado, I would like to introduce Jim Schmidt. Some of you may know him as Alex because he was he was a team member in our last workshop. You may also know him as a small group facilitator in the fall quarter. He is one of our site faculty on the Boise site. And his day job is as a spiritual care provider at Horizon Home Health and Hospice. And I'm going to turn it over to Jim to introduce his team, and then we'll just walk our way through these list of questions. Welcome.
Well, great. It's just a pleasure to be with all of you again and taking time out in the middle of your day to chat with us a little bit about hospice and ask questions. Hopefully we'll be able to answer those for you. We have an awesome team. And so I'm really excited to introduce them to you, and I'll let them actually introduce themselves to you. And I think we have, I just want to check to make sure, Kristen, are you on the call, our CNA?
I am.
All right. If you want to leave your camera up as well, Kristen, that would be awesome. And then I'll just, why don't we just start with, we'll start with Kristen, if you're all right. Just introduce yourself a little bit about what you do, Kristen, and your role on the team. You kind of have a dual role, but I'll let you explain that to the team.
So I'm Kristen. I am the CNA coordinator for most of the branches for Horizon. I coordinate with all the aides to cover all the home health, hospice, and private duty visits. I still go out in the field and see patients. I'm pretty much the middleman between all the patients and the aides, and yeah, that's what I do.
Thanks, Kristen. And Kristen's been with us for quite a long time. She was on the call with us last year as well. How long have you been with Horizon, Kristen?
8 years.
And we have several that have quite some longevity with our hospice team as well. So, all right, then the rest of us, I think, are here. And again, we have some multiple role people that cover a couple of different things today on the call.
Kim or Crystal, Anna on Park 1, Kim or Crystal, Park 1.
Can you see if you can real quick, and I'll have them introduce themselves.
I don't know how to.
I don't know how
Kristen,
to do
before you move on, can you just give us a quick snapshot of what a CNA's scope of work looks like? Like, how often do you go out to see someone, and what do you do, and how much time do you spend when you're with them?
So for hospice, typically we say about an hour a visit. Some take longer, just depending on the cares for that patient. Typically we go out twice a week. We have some, as their level of care increases, that go out more frequently. Sometimes we go out 5 days a week if they're intimate. Others, they just prefer once a week. So really depends on the patient.
And what do you do when you get there?
We have some that we just simply help stand by when they're bathing. We have others that need full cares. We, do all their cares for them. Sometimes we help them eat. We have others that can still do their personal hygiene on their own. So we'll just help them with some light housekeeping, just to help them around their house and help the families out.
That's really helpful, because I think we say that, we do an extra layer of support, but what we mean by that is really what your team is all about. So just really recognizing that the CNAs are the ones providing the true hands-on care.
Yeah.
Awesome. Thank you very much. Who else on your team?
And I
Jen?
think that is very true. Sometimes the CNAs are kind of the unsung heroes. I mean, they are in there doing things that, you know, most of us are glad that someone else is helping with. I would say that for sure for me, for spiritual care. So I totally appreciate our CNAs. They do amazing things. And a lot of times they hear things and interact with family members that we don't hear. And that's why, again, another reason they're so important on our team is that you know, they coordinate with us of, hey, did you happen to hear that so-and-so, this is what they've been thinking and feeling. And sometimes they don't tell that to us, but they will, you know, tell that to the CNAs. So they're super important on our team, and we all value them very, very much.
I
so-
remember you saying that often the CNAs are the confidants because the relationship is so intimate that they are told things that are like secrets that nobody else ever hears. So thank you again for your work
Yes,
and for
very true.
supporting
Thank you.
all the wonderful people that are doing the work.
All right. Well, we go to my right. We'll start on the end. Johnette Flores Miller is our volunteer coordinator, and I'll let her introduce herself.
So I'm Johnette. I've been at Horizon for 9.5 years. And my job as volunteer services manager, because I oversee all of Horizon branches, is to, well, I want to start out by saying in hospice, volunteers, it's a federal mandate that 5% of all hospice patient care be done by volunteers. So when we add up all the hours on an annual basis of the clinical hours, it's my job to recruit, train, and place volunteers with patients in different aspects in order to match that 5% according to the clinical hours.
And what roughly does that translate to in terms of number of hours? Because I don't know how big your census is. Is that 100 hours, 1,000 hours, 10,000 hours?
It's usually between 500 and 1,000 hours. Yeah,
So a
on an
lot of
annual
work.
basis. Yeah, it is when we have multiple branches because it's Horizon wide. So it's all those branches added together in those clinical hours. So it is. But when it was signed into part of the Medicare benefit, they kept that volunteer piece because that's how hospice originated. So it's, I'm very lucky I get to work with amazing people who are here, not as paid, but because they truly have a passion and compassion for hospice.
So what does a volunteer do when they're out? What kind of services do they provide?
We have different categories. So if a direct patient is a passion, they go through an extensive training, and then they go in and they are companions, or they provide respite care and allow the caregiver to go and have some time on their own, keep other appointments. And those are the two most requested as far as direct patient, but they can also do light meal prep, light housekeeping. They can transport patients to doctor visits or just take them out for a Sunday drive. And that relationship is really unique because they don't have an agenda like paid staff does going in. So there's a lot of confidentiality and stuff there of, you know, being with them without that agenda. It's a special relationship, unlike any of the other disciplines. And they can read to the patient. We do music therapy. We have pet therapists. We have we're partnered with another organization that they're trained as our volunteers that go out and just specifically take care of pets for our other patients so that they don't have to give them up prematurely. They kind of help financially and physically take care of those pets. And so, but if direct patient isn't a passion, then they can do what we call community volunteering, where they're the people that they don't normally go into the house, sit down with the patient, but they take care of the yard. They can rake leaves, mow lawns, shovel snow, build ramps, do handyman chores and that kind of thing. So the possibilities are really endless as far as what volunteers can do.
That is awesome. I think this is another piece of the invisible puzzle of hospice that is so critical to, because we can just think about, you know, who hasn't needed that kind of help, and knowing that that will be done for you through the agency. So you can just count on another layer of support. How does the volunteer piece feed back to the team? If they're kind of out there as agents on their own, kind of doing all these things, how do they connect to getting that information back if they learn something interesting?
So for all intents and purposes, they're treated as an employee. So they have a secure Horizon email, and they get patient information. They go out, and then afterwards they have to do a chart note like all of the other disciplines that goes into the system, becomes part of the patient's chart. And so just like Krista and I am there at those interdisciplinary meetings that we have, I'm the liaison between, but the volunteers as part of that team can attend that meeting just as much as anybody else. So a lot of our volunteers are very involved and know the rest of our staff on first name basis. So they're truly just part of the team, and they come and go as they can. A lot of them work full time. A lot of them are students. I get a lot of middle school and high schoolers that want to become, in the medical field someplace. And so we have no age limit, meaning minimum or maximums. So I have kids down, in their 9 and 10 years old, and they're out seeing direct patients with their chaperones.
Wow, that's awesome. I forgot to ask you guys, how big is Horizon? Like, what's your census and how much of a geographic area do you cover?
So we have 5 branches in our area, and they run from pretty much close to the Oregon border. We're in the southwest part of Idaho here near Boise. And so we're say and we are into Oregon, right over on the border into a town called Ontario now a little bit. So we cover from the border, let's see, I would say it's probably about 100 miles east to our other branch, toward heading, I would say just heading east would probably be the easiest way. It's there's a Mountain Home, Glens Ferry, Kings Hill, smaller towns. So
mostly rural population. Mostly rural.
It's a little mixture of both. Mm-hmm. So we cover the Boise area is growing quite rapidly. So the Boise, Meridian, Nampa areas are kind of just blending together now, where like a lot of bigger areas are, which I think that they're saying in the what we call the Treasure Valley area, which includes those cities, are I think over 500,000 people now. Mm-hmm. And but some of those areas are, that we branch off into some of the rural areas, mountain areas where the population is, a couple of thousand people that we cover, like in Idaho City, up in there. And then to the south where there's some rural areas kind of out where like I live. So yeah, we have a little mixture of both. And I'd say our census total, you probably know that.
We're usually around like 120 to 150, depending on what's coming in as far as referrals.
Across all 5 of your branches? Yeah, okay,
Yep.
Awesome. Thank you. Always good to kind of situate because what you are doing with 150 patients and what somebody like Seattle Hospice is doing with 150 patients is not exactly the same, right? Because they don't have to drive for hours and hours to see their clients. There's a lot of other kinds of infrastructure in place if they need extra support. So really just thinking about what hospice looks like outside of cities, and just, how big your reach is, but a lot of empty land in between is really just a different kind of experience, both for the patients and for your hospice team.
So as we move away from the Boise area and the Treasure Valley, I mean, it gets smaller, out into the rural areas, both east, west, north, and, south from where we go. So yeah, it's quite a little area. And most of our census is out of our Boise, Nampa Caldwell area is the bulk of our census, and it gets a little bit smaller in the other rural areas. I was going to tell just a little bit back to our volunteer coordinator program that we're kind of rebooting a little bit is our 11th hour program. You want to tell just a little? I'm going to get it back.
Sure. So our 11th hour team goes through the regular direct patient team. So they have at least 7 to 8 hours of training to begin with, and then they go through an additional 6 where it's more hands-on, taught by our clinical side. And they are a team that when an RN case manager determines that we need extra support for either patient and or family, they will go out, and that we're in the last 24 to 48 hours of life, they will go out in back-to-back shifts of 3 to 4 hours apiece, as around the clock as possible, and acting as comfort care for the patient and support for the family. And so they're very, very well educated and trained on hands-on comfort care, and they're truly really great individuals. So they kind of work on an on-call basis in addition to doing their regular volunteering.
Wow. And you have a backpack?
Yeah, so this is a special backpack. We have a newer version too, but so each of the 11th hour volunteers get one of these, and they're equipped with different things inside the bag, so they all have their bag. And if they get called out, there's, first thing is the emergency chocolate for the volunteers. So there's a little bit of chocolate in there. If they need that little bit of encouragement, there's
Do you have coffee or tea bags in there?
We should incorporate that. Actually, some gloves, there's lip care, there's mouth swabs, gloves, mask. There's a book called Final Wishes in there that we encourage all of them to read, as one of these volunteers. So this group is kind of the special forces group of the volunteers. On care. So they're pretty special. Actually going through some extra reboot process today and tomorrow after we finish this to kind of do some retraining and things. So this is a pretty special program.
And roughly how many of your volunteers are 11th hour angels?
I have approximately 11 people right now.
Wow. That's so
And
cool.
for the immediate area here, not our smaller outlying branches, we usually have about 25 to 30 that are seeing patients continually. And then we have like on-call, one-time special requests and emergency type people that, as we need them here and there, fill in. And that's not including our pet therapy. So we have a great program.
Wow. Well, we still haven't met all your team. This is the
yes,
trouble,
I know,
right?
it's
There's
true.
so many great stories that come up with each one. So thank you.
Yes, Becky, you want
I'm Becky Miles. I am an RN with Hospice. I've worked with Horizon for about 3 years, but been doing hospice for about 4.5. I right now, I'm kind of a smorgasbord of everything. I'm the supervisor over in the Caldwell branch, also case managing as well. I also help out with the Emmett office in the interim. So just a lot of different hats that I get to put on.
And do you also see patients and you go out and to their homes? And so you're a direct care nurse?
Yep, I was a case manager before becoming the clinical supervisor. I still see patients now. I think it's good just for one, I miss it. I miss that patient interaction. But it's good to get those reminders about kind of that case management, what is required to do that, working with the families, working with patients, to keep those skills up.
So some of the questions today, I think, are specifically around sort of, what are the specific roles? And I know that nursing is a very primary role. You all are the clinical drivers of the team, from my understanding. And I'm wondering if you can just give us a quick sense of sort of what's the scope of work for a nurse across the trajectory. So let's say my understanding for a lot of patients, just the overall trajectory in hospice is a lot of times people come either kind of at the end of curative therapy, which may be the last minute, or may have been coming with more foresight. So the transitions can either be hectic in crisis that require some time to settle down and then they can get to steady state, or they're coming in way ahead of those crises and maybe your work is just to keep them out of crisis until the end. So kind of what does the nurse do as both a nurse and also as a case manager? Because you're always doing both of those roles from my understanding.
Yeah, so the nurse will usually have a caseload. Patients are assigned as they come in. We have some that have been on for a while, like you said, where it's more that management is, symptoms. They're more managed as far as what's going on in the home. You're building that relationship more on a longer term. And then we also, as admissions come in and get assigned, we may have patients that are more terminal, more toward that end of life where it's critical that we get in and build that relationship and work with the families and the patients to either manage symptoms or crises that are happening. As a case manager, I feel like it's like the same thing. You wear a lot of different hats. Sometimes you're the counselor. Sometimes, there's been patients I've had before where more so I'm the family is what needs the support versus the patient. So it's really getting in there, getting to know your patient, getting to know your family, what your resources are. Sometimes they don't have caregivers, sometimes they do, or sometimes it's coordinating, trying to find those family members because a lot of our patients, their ultimate goal is they want to pass at home, and we want to make that happen for them if that's their wish. And so really it's getting the team together and rallying everyone to kind of pick up those bits and pieces to put that puzzle together to make that happen for them. So in a typical day, we get assigned visits and we determine as the nurse how often we need to go out. Some patients who are more managed, we see twice a week. Some of them request us only to be once a week. There may be more private. As they start to transition or get closer or need more support, we increase those visits. Sometimes it's 3 times a week, more so often at the end of life where we're there every day, just to make sure that they have that support. They know as far as medications, what to expect as they decline, when to use those medications, reinforce that we're there and that they can call us at any time. Even if it's at 3 a.m., we don't want them to feel like they're alone. We're their support.
Yeah. So one of the questions here was about the 24/7 coverage. And since you were just sort of talking about that, I wonder if you could speak to how does that actually work?
Yeah, so usually our case managers work 8 to 5, usually Monday through Friday. And then we have on-call nurses that are what we call primary on-call for the weekdays and then the weekends. We have a couple on the weekends and usually one on the weekday, but we also have a backup so that in case more calls come in, we don't want them to wait. We don't want a family to wait or a patient to wait. So we have backup in case we get more calls than the one person can handle and they can go out. Typically for a case manager, they're doing maybe 2 or 3 days a month as a backup on call as a case manager. But then we have our primaries that's their normal rotation is they work that, Monday through Thursday after hours. And then same thing with the weekend, starting on Friday at 5 until 8 a.m. on Monday. But there's always a nurse available. And I especially as like any other team member, we reinforce, I've had families were like, oh, I don't really want to call at 3 a.m. because, I feel so bad. I don't want to wake anyone up. And I said, no. We literally have people, that's all that they do. They're expecting a phone call. So do not feel bad about calling at any time.
Yeah. So that's their paid shift.
Creep up at any time. You don't, there's no, and as anyone knows, like that has kids or anyone else, that's like the ER, that things don't happen on normal doctor's business hours, so we want them to feel that support that it's there.
I think
Bob Rutherford is smiling as an ER doc. So I think that point landed well. So do you guys take the calls directly or do you have a call service that fields the after hours call and then gets directed to triage somehow?
Yeah, we have a call service and mostly the reason the call service is to make sure that if like a home health patient, we make sure they get right to where they need versus a hospice patient. So they'll take the message, they relay to the nurse who then calls back, and then kind of triages those.
All right. Because that's, I think, something for what I learned from doing a study of people that are working with, like yours, an agency that serves both home care and hospice, that if you answer hospice to the home care patients, they freak out. And if you answer home care to the hospice patients, they freak out because they're like, wait a minute, don't you people talk to each other? So I have learned that the call service triaging is actually a critical step to making sure that the call gets to the right person who knows the patient and knows what to do.
Yes.
Yeah. Thank you.
I think one of the big things on your question, Helene, about our coverage, and we still have to cross this bridge often, is the interpretation of what hospice provides and how much care they provide when we bring them on service. And we have to, remind the families we're intermittent service. We're not, in home 24/7, which is still some misconceptions about, hospice is going to come in, they're going to have cares 24/7. So part of the teaching process for us is we're going to step you through this, but your family or care providers are going to be the primary, and we'll teach and be here as often as we can and appropriate. But it's that part is still in progress, I think, with the understanding of what hospice can provide.
Well, and it points to a larger social phenomenon of the origins of hospice being a volunteer thing that was really meant to be community support of a person dying. And since our infrastructure doesn't really support that, there's it's not anyone's fault that these services can't be 24/7 CNA care. But when people find out, then they can get mad sometimes because they're like, wait a minute, when you say 24/7, I thought that meant that I got to be a family member and I didn't have to do all the hands-on care. So we do put families in a bind.
I think that's why it's important to get the whole team involved, because we come in and we find out where those gaps are and we try to fix that for them. Try to get in, get them signed up on Medicaid, getting more PCS hours, whatever we have to do to make sure that they're where they want to be with their goals, where they're and trying to meet those as best as we can.
Yeah, that sounds like a fine handoff to your social worker. We need to hear from you.
So Peggy actually went through, I'll let her introduce
I know. I was so happy to see you there. I was like, wait a minute. Did you move?
Yeah.
Awesome.
Made a little job change.
Well, see, this
So
is what we're all about, is connecting our community and making sure that everyone still stays in the circle. So just a different part of the circle.
Absolutely. So my name's Peggy Doyle. I've been a medical social worker for a long time. And I've intermittently worked with hospice at several different agencies, as well as the home health side of the house. I most recently came from St. Luke's, where I was on the palliative care team for 4.5 years. So I do have a lot of experience in all of those realms. My role as a social worker in hospice, oftentimes it's assisting with the admission and consents and paperwork and doing a lot of that education. I have a unique position because I do work the home health as well as the hospice side of the house. So I can have some of those transition conversations when our home health patients are hospice appropriate, and providing that education and having that rapport already built. So helping with the admission, visiting families and patients, most often every couple of weeks, and checking in by phone. I'm always available as needed. Our social work team also has a call schedule. So there's somebody available with the team 24 hours a day. So we just try and help support and assess and kind of watch out for the rabbit holes and be able to patch resources where we can. Of course, I don't know if it's the same way with all of you, but we are in a caregiver crisis here where we don't have enough people to work in the industry. So getting personal care service hours for patients is really, really difficult. So working through families, helping to navigate Medicaid as well as Medicare, and a lot of that education that goes along with it. And really just being that primary support. After a patient passes, our social work team does continue to do the bereavement assessments and check in with our families by phone, and just monitor for how people are processing, how they're getting along. You're meeting your patients where they're at, and you're going where they want to take you. It's an honor and a privilege to be able to do this work.
You know, Peggy, while you're chatting, we had a couple of questions around supporting grief and bereavement. I'm wondering if we could just toss those your way now. So one was, what tools have you found to be most useful when comforting grieving family members and patients? And then the other was, how do you support children who are losing a parent?
We can maybe co on this one.
Uh-huh.
Go ahead.
Yeah, Jim.
I find that probably the most influential tool to use when supporting patients and families is silence and listening, and just truly offering that safe space for someone to grieve, and respecting boundaries. Even if somebody's grieving, it doesn't mean they want to break down and cry. So really being sensitive to that individual and how they're going through their process. For the children question, we oftentimes have younger people that are family members. However, we do have specific resources for helping kids cope, helping kids understand grief and loss and mourning. One thing I always share with patients and families is it's really important to know that a child's first experience with death will shape their view of death for the rest of their lives, unless they go on to do palliative care and social work. And you can change your view, but normalizing and giving kids the room to ask questions, and just letting them know, just like birth coming into life, death leaving life is just as natural.
So one of the cool things, if I might interject, when we do get kids as volunteers, having that experience in hospice a lot of times gives them a completely different view. And real parents are usually when their kids, a lot of times their kids will call and want to volunteer, and the parent doesn't even know that they've done this. And so I always have a parent or guardian come in with the child when we're doing the interview. But once they've done that, and the parents are usually really open for them to do this, it really sets them up to where, you know, if they do have losses, and a lot of times that's how they get to us, is because grandma or grandpa was on somebody's hospice or our hospice, and then they seek us out and they have to volunteer for school and whatnot. But just having them participate in hospice up front when they're younger really sets a great foundation for the tools of life that they're going to, you know, be better caregivers, have a different understanding and a more peaceful and less frightening view of dying and death. And so I think that's why, you know, I'm really fortunate that I get a lot of the younger folks that want to come and really supportive parents, because they think that it's a great avenue for them to get comfortable with that stage of life.
That is so cool. I don't know if you guys have seen this. I think we'll be forwarding this on the listserv of a call globally to be changing our culture about normalizing death. So from the Lancet, I'll share that with everyone. Jim, I stole your thunder as the spiritual care provider. Your quiet thunder is present all the time, which is what I value so much about you.
Yes.
So maybe you can also tell us a little bit about your role, and maybe also extend and add to what Peggy was saying about the grief and bereavement piece, because I know that's really isn't that one of your primary responsibilities?
Yeah, that's another piece. So spiritual care, we've bounced back and forth on what to call spiritual care for a while. You know, I'm kind of landed right now. So whether we're spiritual care providers or we're chaplains, kind of where I've landed recently is, you know, we're providing spiritual care, but, you know, we have professional chaplains that are trained in this, you know, kind of line of work and ministry. But spiritual care is, it's an area that, you know, like you say, touches a lot of different things. And So my first kind of contact with people is to try to identify where they're at, what support systems or faith groups or what they call their faith group or their spiritual connection, try to identify, and get a good assessment of where they're at as best we can so that we can step alongside of them. And I think that's one of the main things I would say about spiritual care is really we want to step alongside people and not bring our own agendas. We have 4 chaplains in this area right here, and we all have a little bit different faith background or denomination attachment or however you want to call it. But our focus is never our own. It's trying to see where they're at and how we can support. And a lot of what I do is say if the family is coming from a Catholic faith background, I try to identify, okay, are you connected? If you're not, do you need help with that? Just was doing that earlier today for a family that Spanish speaking only. So try to find a church in their area, in a rural area that has Spanish speaking priest and get them connected as quick as possible, to the family. So a lot of what we do is connecting, the people we serve with the area that they, feel comfortable with. And some people have, none at all. And they, our spiritual care then might be their front line. Then our chaplains coming in that's the only connection that they have with any type of spiritual care provider. A lot of what we do is listening, and as Peggy said, with things of seeing, help them process and encouragement and just spending a lot of time. Maybe we're holding their hand, or we're, some of the chaplains are more comfortable with, if they want to sing hymns of faith or different things that, we try to provide. I've said before, we're full service chaplains or pastors, so we bring communion to people if they want, or all the different, areas we try to, provide that. Sometimes when hasn't been chaplain or a Catholic priest available, we will go in and say, well, I might not be praying from the tradition, that you're used to, but if you, like prayer or a sacrament, we'd be glad to help provide that. So we're kind of ambidextrous in a lot of areas that we try to serve people where they're at.
And how often how big is your caseload as how often do you go out and connect with people? Is it mandatory? And can people say, no, I don't want that? Then if they do, then what? Does people keep asking them, or do you just wait? Or I know there's a lot of people who are just like, they probably need your help, but they don't want to ask for it, or they think it's something else because they think you're just not who you are. I just wonder how much you have to spend of all your team members kind of explaining your role.
I think that's that does take a little bit of our role as explaining what we do. So with Medicare, we have to provide and tasked with connecting with the family within the first 5 days, as all the disciplines are required to do. The families, our intake, our nurses and social workers who make first visits for consents, they're kind of giving them information that, about spiritual care, and that they will be contacting you and unless there's some real specific reasons why they don't want any contact, which we can just document that they want zero contact. But most of the time we at least get a phone call and then try to, explain a little bit about what we do and kind of hopefully disarm the situation of what expectations, because certain words and, chaplain may just, for some people, have certain context of, oh, I don't want that. That's a certain group or,
right.
And so there is a certain amount of that we try to disarm them, and that's not why we're here.
Right.
But as far as visits, I try to see everybody that, comes on service. Some people I see weekly. as per their request. And I think all our chaplains try to just customize that care of how often would you like to be seen? And again, that could be once a week, every, twice a month. And then as we get closer to end of life too, sometimes that might be every day as well, going in to spend time with the family.
And are you there for an hour, 2 hours, 15 minutes? How long are you there?
I'd say yes. And sometimes I think we have a little bit more flexibility as the spiritual care providers of being, where we could come in and spend an hour with somebody where, sometimes the nurse or CNA or social work, they're on to, more critical need, where sometimes we can spend an hour or so with people if that's what their need is. So we.
And do you do televisits too?
We have done those a little bit in the last couple of years. We've been able to get back into facilities and homes a little bit more the last few months, which has been really good. It's really hard. That's been a challenge, I'd say, for me specifically for spiritual care. Really hard to provide good spiritual care over a camera.
Yeah.
The other piece too, if I can add to that, Jim, is
this is so we didn't get quite get, we're still getting our introductions, but Sue, if you kind of want to huddle in here a little bit. Sue is our director of nursing, yeah. So sorry.
Hi, sorry, I didn't mean to interrupt. I was just thinking of a situation where I don't remember if it was over in your branch or not, Becky, but we had a patient who was actively dying, and it was important to the family that this family member, they knew that she would want a prayer, someone to pray over her. And there was no way the facility was going to let the chaplain in, and they'd already let one too many family members in at that time. They were anxious about it, but at least she got to have some of her family members in there. And so the nurse said, can I call the chaplain and have him give a prayer? And he was able to, maybe it was Ron. One of our chaplains, they were able to give a prayer over the phone. And it was, he felt like, gosh, he could have done more, but it meant that right there meant so much to the family that we were at least able and willing to do something like that.
Yeah, we only have 15 minutes left as it is, with many more questions and time to answer, although I do think we've answered many. What else do you do as director of nursing, Sue?
Oh my goodness.
Are you the master person that runs the show?
Yeah, well, yeah, I'm the director over all disciplines. I'm luckily I have amazing clinical supervisors like Becky, where we have 5 branches, and we meet weekly and more often to talk about our needs all throughout the agency. I try to attend every IDG meeting that we have with our doctors. I'm over compliance because we're Medicare paid. So in order for us to, get paid by the government, then they give us these rules called our conditions of participation we need to follow. And so we come together on ways to best implement those things. We have a great medical record documentation, and that helps us at times to be compliant, but it still takes a human to watch over those things and make sure that we have entries that are compliant savvy.
Right.
It's
I think that's a piece that people fail. I mean, when you're so dependent on Medicare dollars, and working for Medicare is a hard business to be in. And the bureaucracy is enormous. It's not a trivial task to both deliver high quality care and get it written down the way it has to be written down to get paid for.
Right.
So
we really try to stress, don't let the device dictate the care for the patient, that we find a way to go out and deliver the care that's needed. And then if we have to figure out on the back office way, how to make that count or how to fix things, that's the most important thing. If we put the patient first, we can't go wrong. So.
yeah.
And
I
it used to
wonder-
be that, oh, sorry, I
Go
was just
ahead.
gonna say,
No, go
so
ahead.
there, I don't know if the hospice of the up in Sun Valley, we used to have a hospice in the area, just in the Sun Valley area. Some of you might be familiar with Sun Valley, Idaho. We had a freestanding hospice there, and I was part of a coalition and had the director on our coalition, but there was a freestanding, so they were not Medicare funded. They were completely donation-based freestanding hospice. And so that they're one of the few that, I don't know if they're
It's
still,
probably the only one in Idaho.
yeah,
It's Hospice of Wood River, I believe.
Wood River
is
Valley,
what I
yeah, that's
read.
right, yep.
Dr. Perry, one of our hospice physicians, who is the palliative care doctor for the VA here in Boise, her parents live there. And she
Corona?
actually said it's struggling right now. I'll say, how as a nurse.
And she
Perry?
went through our program as well. Dr. Perry went through the program.
Yeah, I was just saying, she was one of our first cohort. I love this network. It's just the coolest thing ever.
It's awesome.
We are getting short on time. And one of the big questions was, how do you guys take care of yourself? And how do you, I mean, for people who don't live on the inside, it's hard to understand how you would sign up for something that on the outside just looks like a heartbreak every day. I'm going to translate that. And I think actually, Christy said it well. Isn't it hard to deal with death? It must be so sad. How do you do it? This must be the question you get asked all the time.
Well, I think I'll let jump in here too, but I think one of the things, a lot of times spiritual care and social workers have to remind the other disciplines at times about boundaries and what we can do and where we need to say we can't do sometimes. And that speaks to the love and care that our team wants to provide, our patients. But self-care is super important. We have a meeting once, we just had it yesterday. We call it our quality meeting, where we gather as our team and talk about the deaths from the prior month. And Sue has been gracious on this meeting that I read the names of the people that passed away. We have a period of time that the team can talk about those deaths, and not necessarily the death, but the person and the family, what the memories, certain, events that maybe happened, whether it was, straining on the team or whether it was really just something, really positive. So we have kind of some debrief times that we do at least once a month, which are really important, I think, for all of us to be able to, we acknowledge, I mean, this is not easy work that we do, and we are around death a lot, and we never want it to be like robotic for any of us that, this is, revolving door of in and out, that these are families, these are, patients and people that have had a lot of things go on. And I was reminded of that, recently when we brought my uncle on to our hospice service, and the difference of being a clinician and being with people, but now when it's you and the emotional things that happen, so it's self-care is super important and ongoing all the time.
And just so everyone else knows that self-care was Jim's third quarter project, was to create more opportunities to invest in self-care at the level of the agency and each of the people that works there. So another example of third quarter talent that is probably still a work in progress, I'd be willing to bet.
It is, yes.
So, and that's the beauty of this work, is that it's really just planting the seeds for things that can manifest over time.
Well, and as a former RN case manager, I mean, I'm an RN still, but I case managed in the beginning with hospice care, and just being a part of the IDG team and, hearing about some of the amazing things we're able to do with these families, and kind of to help with their organization, and to hear, or to be able to read thank yous back to the staff on families that said, we couldn't have even known where to begin without you. And sometimes we're in there for just a little while and don't realize the impact that we made. And, you know, the importance of urgency in the care that we provide. You wouldn't think there'd be urgency in hospice, but there is. I mean, when somebody needs a nurse there, they need a nurse, whether it's for reassurance or for, you know, symptom management. We really, our job is to help empower that family. When you have that satisfaction that you've been able to do that with that family and make it the best it can be. You know, as a nurse, when you come from an area of being focused on healing and making it better, and the whole world's like that, nobody talks about death. And then in the world of dying, you realize how much people need to focus on something besides the death that's happening and think about the quality of life that can happen now.
Yeah. Yeah, I think just,
So for me,
please.
I might be short on time, I'm not sure. Go ahead, Helene.
Yeah, we are running out of time, and there's a couple really big questions. I mean, I think just what I've learned over time, I was a hospice volunteer as well in a previous life. So just the sacred moment and the privilege of being present for something so important in one's life, and being able to make that last chapter something that people don't look back on with fear or sad, you know, the traumas that are left behind.
it's almost like, I can't believe you're letting me play.
Sorry, we were just, go ahead. Have some other bigger, a couple of questions.
So I think there's a couple that were talking about the range of services, and I think Teresa is on the call, and she had a question about tube feeding and kind of how does one explain to a person who's dying about the benefits or harms of tube feeding at the end of life, especially when there may be spiritual connotations about withholding being equivalent to starvation. Everyone could, I know if you guys have insight on how you do that, that would be wonderful to hear, because I think that's a really hard conversation, and we're just curious.
I think
how
probably
you
all
do
of
it.
us could answer that in a
Yeah.
different way.
But our philosophy isn't for people that they have to stop tube feedings, you know, especially if they already have a PEG tube. Some have tried NG tube feedings. We do explain, you know, as the body shuts down, some things that can happen with fluid overload. We make sure that we're giving good education so they understand and what to watch for when it comes time to maybe slow down or to stop it. You know, we really have a philosophy of, to an extent, of people have choices when they're in hospice. We want to focus on quality of life, but, you know, kind of get to the underground of why they want to continue this tube feeding too, and what are the importance, and is that really based on good knowledge.
Kind of like what we've just talked about in the last, or the first two quarter, you know, in the quarter that we're in with the program is, you know, what's important to the families and on our patient, and aligning with them and once we understand what their goals are and what is important to them at this time of their life, that we can kind of, as Sue was saying, kind of describe our care or describe what those types of interventions look like, and you know, the whole idea of you know, in our learning experience of saying we might be in a different place right now with where we're going and where, you know, where you're at physically on this journey. So,
And if they
Is this one that they punt to you as spiritual care, to if they're sort of saying, but aren't we starving them to death? Do you guys have
I
an
have
answer
had
to that?
some over the years where they're talking, well, if I don't do this, am I, you know, hastening death? You know, am I contributing to a quicker demise of my loved one? And so navigating that with them and part of that is, you know, education with the nurse of what that looks like. But
we kind of like
those
to meet
are-
all together as an IDG
Mhm.
team with the family, if that seems to be
Mhm.
one of their concerns. So that if there is medical stuff that comes up, the nurse is there. You know, we really try to give them information about nutrition at the end of life, if the tube feeding isn't already in place, and, you know, it's not really that beneficial at this time in their life. It could be more harmful you know, in some circumstances, and help them have good information to make a decision with and feel supported on that.
yeah, there are definitely some spiritual parts of that over the years of trying to navigate with people of, okay, well, if I do this, I feel like I'm prematurely ending their life. So those are some areas that we have to try to navigate sometimes, and those are
And this is
definitely
the
not
quality of life that they would
easy.
want you to
Yeah.
preserve.
Yes.
And let's look at their advanced directives. What do they want?
Mhm.
I think a lot of families, food equals love. That's how we care for people. The way I explain to my patients and my families is, when we all get together as a family or as a group, what's the thing that we usually do? We're usually eating or drinking, right? It's like, hey, do you want something? It's a barbecue. It's a family get together. We're meeting at a restaurant. So it's hard for families to understand that appetite declines. They don't feel hunger. They don't feel thirst. And they feel like if they're not offering and doing that there's something wrong. So a lot of times it's just education, because what you don't know, you don't know. And so bringing the team in, because we all kind of bring a different piece of this, but explaining about how the body starts to shut down and what happens, and that actually giving them food or fluids could be detrimental. We could, risk aspiration. It could just, nausea. There's so many things that can happen with it. But explaining that it's not that we're withholding, offer. And if they want to partake, that's great. But if they don't, we don't want to force them. I kind of always given this to my families and say, when you eat Thanksgiving dinner and your eyes are way bigger than your stomach, and you feel like if you're going to bend over, it's all just going to come out. And just how uncomfortable you feel for hours. I'm like, that's how they feel when we push food or fluid on them, when they're not hungry. And a lot of times patients will try to eat or try to drink because they think they're making their loved one happy. And so really it's walking them through all of that and what the consequences are if we continue to do it. But once they understand that that's part of the normal decline, we get a lot more willingness, and it's not scary anymore. They don't feel like they're, keeping their loved one from eating or drinking. It's not like us, where if we stopped eating or drinking, we'd feel pain, and
Right.
They don't feel that. And so really walking the family, and sometimes even the patient through that, is.
Can I ask a related question? Dr. Powell is on the, Susan Powell's with us, and she manages the Washington Death with Dignity requests, and asked about that. And I know it's not legal in Idaho, but I'm curious, do people ask for voluntary stopping eating and drinking? And does your hospice support people who choose to withhold and actually choose that as a way to hasten their death? How does I know that's many hospices struggle with how they feel about that. And I'm just curious, because you can also need a little bit of additional symptom management if that takes a while, from my experience, especially in that initial time period while they may be moving toward a delirium state where they're, kind of ketonic. So I'm just curious, what availabilities does your hospice provide people who are choosing that as their exit plan?
Well, a couple of things with that answer. We don't live very far from the Oregon border.
Yeah.
So we have patients bring that up because they don't know what they just know they could do euthanasia in Oregon, they think.
Right.
It's a process there. But here, yes, we had a patient, we haven't had a lot, but we've had a few. I can remember a younger patient who had a slow growing type tumor, brain tumor, and her family didn't live around. And she always said she wasn't going to make it a difficult time for her son. She first tried to take all her Ambien. And then when she was in the hospital, Dr. Walker, who was our medical director, was the palliative care program leader there in the hospital at the time, and was able to talk with her. And she was very sensible about what she wanted. She wasn't having any dementia or delirium or anything. They wanted to call a psychiatrist in for her, and he didn't feel like that was appropriate because she, was making a decision based on a lot of forethought. And she did come to a point because she was really, like starting to put things in the microwave and forgetting about them, put it in on there for 20 minutes and the neighbor had to come in and catch it. And she did quit eating and drinking. It was difficult for the team, to know that she wasn't to a point that she wasn't feeling, hunger partially, but was making a conscious decision. And we just kept her comfortable and talked about it in IDG. And Dr. Walker had some very good comments to help us feel as much at peace as we could, and kind of brought it back to her disease process and her individual decision.
I think and to piggyback on that, I don't know if it's always in our repertoire when we're with families that we're saying that as an option. I think we're kind of feeling that out as we go. So it's not like, well, if on every visit kind of thing where here's your options and you don't have to eat if you don't want. But I think it's kind of that we're trying to be in tune the best we can of when we identify the person is kind of along that vein of like, well, this is an option for you, that you don't have to eat and you don't have to drink, but we haven't had a whole lot of those experiences. So.
I think as a case manager, it's meeting the patient where they're at. What are their, I guess I feel like it's no different than if a doctor offers treatment or says, hey, this is what we think you should do. As long as they know and are educated about it and they know what the consequences are of not doing that treatment or not taking that medication, and they're okay with that, we're really aligning with their goals and where they want to be. So if that's a decision that they make, we as a team have to support that, even though it may not be something we would want to do.
Well, those sound like wonderful words to end on, because we are at time. And I can't thank you, team, all of you, for phoning in and sharing your wisdom and getting a wider angle camera next year so we can keep Peggy in the picture, but we know she's there. And to you, Kristen, for joining in from wherever you are as well. Please accept our gratitude for sharing your thoughts. I'll stay on if anybody has additional questions, but otherwise we release all of you back to your day. We hope this was helpful in answering your questions. I think we got to almost everything. We could spend another hour on diverting admissions and what do you do for the 11th hour patients. We don't unfortunately have time for that, and it's an important question. So maybe we'll find another venue to answer some of those. So with gratitude, thank you all for showing up today.
Thank you.
Thanks for having us.
Thank you.